Even the smallest idea can spark big change. At HEROC, we see it every day, with organizations across Canada finding new ways to create the safest healthcare system. On Share, Scale, Repeat, we talk through some complex topics in healthcare, interviewing the brains behind the projects that are keeping Canadians safe. We're doing this so you can find ways to scale the information where you work, because safety can't happen in silos.
Hi everyone, it's Abby. Thanks for joining us on another episode of Share, Scale, Repeat. I'm here with my co-host Trevor Hall. On this episode, Trevor and I chat with Erin Kennedy, Director of Mental Health at North Bay Regional Health Centre. We learn all about their project that received a HEROC safety grant, which focuses on trauma-informed care and de-escalation training. Trevor, what was your favorite part of the episode?
Yeah, it's such a great discussion. My favorite part was Erin's powerful message on why a trauma-informed approach in healthcare is so important. I love learning about the project's impact on staff, patients, and families. Enjoy the episode.
Hi, Erin. Thanks so much for joining us on Share, Scale, Repeat. How are you?
I'm great, thank you.
To start off, tell us about yourself.
I'm the Director of Mental Health at the North Bay Regional Health Centre. I've been working with this organization in our mental health portfolio for 14 years. Before that, I am an occupational therapist by trade, and most of my work was based in community mental health.
We're going to be chatting about the project your organization undertook around trauma-informed care and de-escalation training. Before we get into it, can you tell us why a trauma-informed approach in healthcare is so important?
Yeah, most importantly, the research is there. So we know that trauma-informed approaches reduce instances of restraint and seclusion, enhances patient outcomes, and improves overall staff satisfaction. So it's a bit of a slam dunk approach. It's evidence-informed, it encourages compassion, it promotes safety and dignity, and it's universally applicable across our organization. So it's well aligned with values and priorities that we would see in healthcare. Would it be helpful if I talked a little bit about what trauma-informed care means?
Yes, please. Go ahead.
Okay, so trauma-informed care is really about the understanding and the application of that understanding of how a person behaves and reacts today based on the influences and unique histories from their life. So we use the term personhood, and that includes just everything about who you are and why you've come to be the person that you are today. So when we think about a traumatic experience in somebody's history, we know through a trauma-informed approach that how somebody reacted to a current context or a current setting is actually impacted by something we might not be able to see. So, for example, just a very simple hypothetical scenario might be to have somebody who is refusing medication, but that same person may have had a choking experience in their past, and they may not even be consciously linking those two. But if it was important to that person, it could impact how they're perceiving the context today of having a similar experience. So for our staff, when they understand these concepts, it's really a matter of putting judgment aside about why we think a behavior is happening and shifting the focus instead to creating a safe and comforting space for all of our patients. Additionally, it's really great because it not only applies to patients, it applies to visitors, it applies to other care partners, colleagues, and it also creates a space for our own self-reflection about what we're bringing to the table.
Thanks so much for giving our listeners background on the why behind your project before we get into the what, and really reinforcing the value of trauma-informed care. You received a HEROC safety grant for your work around this. Tell us about your project, Erin.
Sure. So North Bay Regional Health Centre has a longstanding history where we were providing crisis intervention training for all of our staff. But this project was about adding in the trauma-informed care concepts so that staff would have more tools to create the safest environment possible. And these trauma-informed care principles would help de-escalation. So the design was fairly simple. We wanted to have a trainer model pulling from staff and leaders in our organization where they would be trained to be able to deliver trauma-informed care material. We would arrange to have training sessions set up. We would make the training mandatory for all staff. And then, of course, evaluate effectiveness and engage in continuous improvement. And that's what we did. And it went really well. The participants, the trainers had a really positive experience. I know I was starting to hear trauma-informed language and jargon in care planning and in documentation on different environments. But what we noticed after about a year is that attendance was waning. So we had a really great curriculum set up, but we were having a hard time getting all of our staff to be able to attend. Bit of context is that our hospital has more than 2,000 employees. And as a hospital, obviously, many of those are shift workers, not available during business hours. In addition to that, we have other mandatory training. We were continuing on with the crisis intervention training. So ultimately, we realized with a bit of an aha moment that we needed to look at condensing our mandatory training into one single event. So we actually blended crisis intervention with trauma-informed care. But that wasn't only operational, it also helped make that direct link between how using a trauma-informed approach would help with crisis intervention. So it was more efficient and also more effective. So at that point, when we realized that we were going to be tackling the curriculum by blending those two courses, we decided to do a little bit more work as well. So we added additional training for our trainers, but we also got their input on how that course could be most meaningful to the audience because they were the experts. They were the ones that were actually engaged and seeing how it was playing out. We added more case-based learning. And this is when we started looking at fit for purpose. So we had different curriculums based on where you worked and what kind of people you were encountering in that environment. And at this point, we also moved the project front and center in the organization by adding it to our quality improvement plan and focusing on the increased attendance. At this point, when we were really looking at attendance, we looked at this in a few different ways. So we were working with staff schedulers at this point. We had a coordinated effort between the education team and the mental health team. We worked on marketing with promotional material, marketing internally across our staff to garner that buy-in and help people prioritize attending these sessions. So that might be at staff huddles or posters and even at executive meetings. We added in a feedback form at this point. And of course, because this was on our QIP, we were following up every month with department leaders on their progress. So really just leaning into the importance of this project across the entire organization for all areas. So now at the end of that second year, we're starting to continue to look at our next steps for quality improvement.
And going over everything you did around engagement is so helpful for our listeners. And we know engagement is a huge piece around training. So how did you engage your senior leaders to make sure it was part of the quality improvement plan?
Well, we were quite lucky because this actually took no effort at all. Restraint and seclusion had been on our minds at our organization, and we had a large-scale training event that included clinical staff, leaders, and senior leadership. And our president and CEO at that event had the opportunity to really hear from our clinical staff. And it was his suggestion that we prioritize staff development at that point. So from there, our project was launched and continued to have that executive support and eventually landing on the QIP.
This is absolutely fantastic work, Erin, to you and the team. Congratulations, North Bay Regional Health Centre. I really like what you and Abby were talking about. It's about focusing on safe, comforting space, putting judgment beside. And how do you really blend not only crisis intervention, but really that trauma-informed understanding, seek to understand that fit for purpose for the best quality of care. I'm wondering if you may be able to talk to us a little bit about the value of equipping staff with the skills to manage in crises.
Definitely. So in the terms of our project, we would consider a crisis someone whose behavior is impacting the safety of the staff on the scene. So this could be any of our staff facing a patient, a visitor, a colleague, anybody who is presenting with risky behavior, risk to the physical or psychological safety of our staff. So maybe thinking about somebody and the impact that they would have through shouting or threatening or insulting behavior, even if physical harm isn't present. So there's a continuum of early signs of agitation leading up to this type of risky or escalated behavior. And we want staff to be prepared to safely intervene along the entire continuum. So it might seem like providing staff with training to manage somebody who is at the peak of physical aggression would be the solution to most ensure their safety. And we do provide this training, of course. But in reality, avoiding that situation altogether is how staff would be safest, by not even having to encounter that situation at all. So we really look at it as that continuum. And by focusing on de-escalation and what happens before an incident or crisis, again, using those trauma-informed principles, in addition to the more traditional crisis intervention, the risk of occurrence is already reduced. And even with our best effort, when behavior does escalate to the point of a crisis, the same principles apply to de-escalate from there as well.
Yeah, absolutely. Well said. I think, again, it really speaks to the holistic fashion in which you're approaching this. Again, not only speaking about physical behavior or psychological, but the totality in which we're humans, and equipping not only our clinical staff, but our full teams with the understanding around early signs and how do we go about doing this. How about that? So can you tell me perhaps maybe why it's important to include staff across the organization? Specifically, I think that you mentioned that, or you were thinking about sharing around finance teams and even our culinary kitchen staff.
Definitely. Well, this is pretty simple. We just want to make sure that all of our staff are safe no matter where they work. Anybody who works with people is at risk of encountering somebody who might escalate, acknowledging that the frequency and severity might be different in each role, which is why we've adjusted our training depending on where you work. So for example, somebody who is in finance might receive different training than somebody who works in one of our forensics mental health units. But for anybody to be able to detect those early signs of escalation or know that they're entering a contentious situation, we want them to have the skills to ensure a more positive experience for both parties. So, for example, somebody in finance may receive a call from somebody who's agitated about their pay stub or looking for answers for something that they're not understanding. And that could be a situation that escalates. And we want to ensure that both parties are feeling safe in that discussion. For our kitchen staff, our food services team, and I want to say I've seen a lot of great compassionate work from our food services at North Bay Regional Health Centre. They may be bringing a cart to the unit and have somebody approach and try to get into the cart instead of waiting for staff. So they could react by pushing the person away, pushing their hands away, telling them no. That's maybe a riskier choice. But if they shifted to a position of considering, why is this behavior happening? What's going on with this person's history? Maybe they have a history of food insecurity or any other reason. Maybe they're just very hungry and it's causing them discomfort. So if they changed their approach to saying something like, wow, you must be so hungry. If you wait in the dining room, I'll get somebody to bring it right over. It's just a far more compassionate approach and less likely to lead to an escalation.
Yeah, no, really well said. I think it's putting the human back into humanity, and together we're stronger. I really like how you're mentioning, again, this is about North Bay Regional Health Centre in totality. This is about recognizing early warning signs and equipping the right tools at the right time for the right people, all in the betterment of patient care. Now that the project has closed, Erin, what impacts are you seeing on staff as well as patients and families?
Well, I would say that the areas that I was mentioning before that maybe had been overlooked for this type of training are definitely feeling supported and engaged. We've gotten some great feedback from those areas. I know clinical records was another department that was really happy to be participating in this training and being able to put it to use. We're starting to really refine our data collection. So over the next year, we're going to be truly monitoring the clinical impact as measured through incidents. It's hard to identify an incident that could have happened but didn't because somebody started with a compassionate approach, of course, but we're hoping to see downward trending of code type scenarios. Absolutely. Additionally, our effort in having staff attend training has data to support our success. So looking back year over year, back in 2023, we had under 300 people attend over the course of the whole year. Where we're sitting at this point, over 267 staff attend this year. So with a straight line projection, we would be looking at over 1,000 people participating in 2026. So definitely having staff attend these sessions means that there's buy-in, interest, and motivation.
Really well said. I think that interest, that motivation, that drives change, that allows us to start with ourselves and move out from there. At HEROC, we're really about scaling knowledge across the reciprocal and beyond. What's one thing you may wish you learned sooner while building the project? Something other than healthcare organizations can learn from? In other words, what do you wish that you knew 2 years ago before embarking on this journey?
Well, we definitely learned a lot about the operational aspect of staff being able to attend mandatory education, particularly looking at the volumes. As I mentioned, you could have the best curriculum and content, but it does no good if people aren't actually able to attend and receive the training. So if I could go back in time, we would have given that more attention, and definitely we would have blended the two curriculums sooner. On the other hand, we did make a few decisions that had an even better impact than I expected, so I would definitely recreate. Having trainers selected from frontline staff because they can share those real world examples of how to apply that learning. And definitely our collaboration between the mental health portfolio and our education team that gave us such greater reach. And it was such a positive experience when it came to problem solving. Our education specialist and our mental health practice manager are both equally motivated in the project. And so everybody working together with the same common vision really helped, particularly when we were pushing to increase attendance.
Such an amazing journey, right? Like starting with the concept, seeing two major principles or theories and bringing them together. Most important piece is creating that action. And well done again to you, team North Bay Regional Health Center. Like it's just absolutely great to create that individual action, but also collectively as an organization. Our last question may be building upon the successes of this great work. What's next?
Well, the work continues on. It's actually on our QIP for another year. So we're going to be monitoring closely and adjusting as we go along to make sure that the momentum that we've seen so far continues. We have a few optimization tasks. So we're continuing to receive feedback from our participants that we're analyzing, and we'll be using that in our quality improvement as well. And we're going to start auditing sessions just to make sure that we don't drift. So we'll be developing a protocol and a schedule to make sure that our trainers are supported and have the opportunity to bounce ideas off of somebody that's actually sitting in on their sessions. We also have a new metric that I am excited about. Our full senior leadership team will be attending the training sessions with clinical frontline staff. So they'll actually be in the same classroom setting. And then following that training, the senior leadership team is going to be visiting different departments across the organization to discuss what it really means and how it's helping frontline staff in their work and what still needs to be done. So continuing to look ahead and having that executive endorsement, I think that we're really going to continue to push the envelope further.
So cool. Yeah. One team, one group, one culture. I really think that we are seeing change and creating action is just beyond amazing. Thank you, Erin Kennedy from North Bay Regional Health Center for being on our podcast today. Abby and I have learned lots, and I know that our listeners will as too. I think it was the infamous Anna's Nin that talked about, we don't see the world as it is, we see it as we are. And I think it's quite foundational to this conversation where putting judgment aside, focusing on safe, comforting spaces, creating that blend of crisis intervention with trauma-informed care, trying to find that fit for purpose, really to understand how do we create the best healthcare systems, but also the best individual experiences, not only for patients and their support networks, but for ourselves, our teams, our regional health center in total. Today, sharing knowledge is really what Share, Scale, and Repeat is about. It's about discovery. It's about understanding. And it's really about sharing on things we don't always talk about in healthcare. So again, Erin, on behalf of HEROC, myself, Abby, thank you so much for sharing this great work. And we can't wait to hear how the next year goes. Thank you again.
Thanks for listening. For more interviews, be sure to follow our show wherever you get your podcasts. If you like what you hear, please rate and review the show. If healthcare innovation is your thing, check out HEROC's award-winning leadership podcast, Healthcare Changemakers. And don't forget to follow us on LinkedIn to see the latest news in risks, safety, insurance, and more. Share, Scale, Repeat is recorded by HEROC's Communications and Marketing team and produced by Podfly Productions. Have a question? Email us at communications@heroc.com. Until next time.